The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Jackie Leiser, and I'm a manager with CAQH Core. Welcome to our first town hall of 2023, and thank you all for joining us today. Before we get started, I'd like to review just some quick logistics. If we could move on to the next slide, great. And this is just how to access our webinar materials. So if you take a look at your GoToWebinar menu, you can download the slides right now directly from the handout section. The slides and recording of today's presentation will also be available on our events page after the webinar, and we'll also send out an email to all registrants in the next 1 to 2 business days. If you'd like, you can ask questions at any time throughout the presentation, and you can do that in the questions panel of the right-hand side of the screen as well. I'll do a quick run through of our agenda. For those who have not joined us in the past, we'll provide a brief overview and background on who CAQH Core is. We'll also give an update of our operating rules recommended for federal mandate, followed by an overview of 2 federally proposed rules. Next, we'll cover our upcoming operating rule development initiatives for this year, and then we'll wrap things up with a call to action and an audience Q&A. With that, I'll hand things over to Erin Weber.
Great, thanks Jackie, and thanks everyone for joining us today. I'm Erin Weber, and I am Vice President of the Committee on Operating Rules for Information Exchange, otherwise known as CAQH Core. I know we have a mix of new and old contacts attending today, so I want to welcome everyone. I'm going to give a quick overview of who we are and the work that we do. For those of you that are new for the organization, beginning on slide 5, CAQH Core is an initiative of CAQH. CAQH is a nonprofit organization with a mission to streamline the business of healthcare. So we have a suite of products focused on the intersection between payer and provider data exchange, where if there is a single source of information exchange for administrative data like provider credentialing data or coordination of benefits data, CAQH creates industry utilities to support the exchange of that information in an efficient way that reduces burden for both plans and providers. Also within CAQH is our Insights initiative, which produces our annual CAQH Index report, which I would encourage everyone to go take a look at. The most recent 2022 report came out just about a month ago with updated data on the industry's progress towards automating administrative transactions. So you can get a sense of what percentage of eligibility transactions are conducted electronically, how much are manual transactions costing our industry. It's a really useful report for giving an industry level perspective on the opportunity we have to reduce administrative costs and burden across our industry. And then our third initiative at CAQH is CORE, and CORE was founded about 15 years ago after the passage of the HIPAA law, which requires industry to adopt electronic transactions for common revenue cycle exchanges like eligibility, claim status, payment remittance, claims, all of those transactions that I know most of you are very familiar with. What happened was as the industry began implementing these transactions in the early 2000s, there wasn't a lot of consistency in how the data was exchanged and what data was exchanged. So it made it very difficult, particularly for provider organizations, to automate their systems. I think the best example is the eligibility transaction, where the standard only required at the time that plans send back to providers an eligibility response, yes or no, this patient is eligible, and no information on, what types of services the patient is eligible for, what benefits are included in that coverage, what are the patient's financial responsibility around copay, deductible, coinsurance, and there were no rules around how and when that transaction should be sent. So the industry came together and created CORE, modeled after the financial services industry, to develop operating rules or business rules to sit on top of and build on those standard transactions. So for example, eligibility operating rules, which were the first set of operating rules developed by the core participants, addressed requirements related to the data content of the eligibility transaction, requiring that some of that coverage information specific to service type codes be sent back in the transaction. Also, that patient financial information, as well as requiring that that health plans support that transaction to be exchanged in real time using common connectivity methods. So really simplifying and putting more uniformity around those administrative transactions. CORE started as a voluntary initiative. Organizations were developing and adopting the operating rules because it made good business sense. We did a number of ROI studies that really demonstrated that operating rules helped reduce denials and costs across the industry. Ultimately, through the Affordable Care Act, CORE was named the National Operating Rule Authoring Entity for all HIPAA-mandated administrative transactions. So under HIPAA now, through the Affordable Care Act, all of those HIPAA-mandated transactions now require operating rules as well. So some sets of our operating rules have been federally mandated through this process, and some sets are still voluntary. Again, an industry is implementing them because it's good business practice. We see our role in the CORE team and our staff, who you'll hear from today, we see ourselves really as the facilitator of this work. We have participating organizations that come together, participate in our subgroups and work groups to develop the operating rule requirements, and it's really driven by the industry. We then support the adoption and education and awareness of operating rules, measuring the impact of operating rules, and we have a certification program as well to help drive adoption. On the next slide, I just want to highlight our more than 100 CORE participating organizations at this point. Health plans participating in CORE represent more than 75% of covered lives. So we really do have a broad swath of the healthcare industry, from plans, government agencies, vendors, clearinghouses, associations, all coming together and having sometimes some really challenging discussions around how we can push the industry forward to a more interoperable environment. A little bit more detail on the next slide for those of you who are new on what is exactly an operating rule. And I mentioned that CORE was modeled after the financial services industry. The financial services industry has been developing operating rules for years and years and years. And I think the best example of that is the ATM network. You can go, anywhere in the world and go to an ATM machine, and that machine will contact your own financial institution back in the US or wherever, know your balance, and be able to deliver money to you right there at the point of service in real time. That's all because the financial services industry developed operating rules to support that data exchange. They did it on a voluntary basis, and it still remains voluntary in financial services, but healthcare, we always kind of need some mandates to move us along, it seems like. The formal definition in the Affordable Care Act is that operating rules are the necessary business rules and guidelines for the electronic exchange of information, not defined by its standard or its implementation specifications. So an operating rule can't conflict with what's already in a standard, and it cannot duplicate what's already in a standard. And a good example of that was when the industry moved from 4010 to 5010 for the X12 transactions. Any requirements that were in 5010 that previously were in operating rules had to be removed from the operating rules because we don't repeat what's in the standards. So the next slide outlines our operating rules to date. To date, the CORE participants have developed 8 sets of operating rules, and they really support the entire revenue cycle functions, from the time a patient visit is scheduled through the eligibility and benefits inquiry, all the way through that claim payment and remittance advice on the back end. We also have rule sets that support the data exchange between health plans and employers for transactions that are also mandated under HIPAA. You can see here the rules in purple, I guess that's purple, are federally mandated now. We have some new rules that are highlighted here as of about a year ago, as well as several rules that are either with the National Committee on Vital and Health Statistics to be updated or to be newly federally mandated. And I'll talk a little bit about that process in a few minutes. I mentioned that we have a certification program, and on the next slide, I just want to share the value of that program. We offer core certification for every set of our operating rules. So technically an organization can earn 8 core certifications across those certification sets. Any organization that creates, transmits, or uses any of the administrative transactions impacted by the operating rules can become core certified. We have an independent testing vendor that we work with that facilitates the system being tested, going through a series of test scripts that have also been developed by the core participants to determine whether that product or system is operating in conformance with the operating rules. To date, we have awarded 406 core certifications. We also have a recertification program. So organizations have to reconfirm their conformance with the operating rules every 3 years. We didn't used to have that, but suddenly we are now a 10-plus-year-old initiative, and we really recognize the value of ensuring ongoing conformance with the rules to ensure that certification means something to the industry. One of the things we've observed over the years as well is that both health plans and providers have increasingly been requiring their vendors or their clearinghouses to become core certified as a condition of contracting. So we have many vendors and clearinghouses that have come to us that way, particularly for the federally mandated operating rules. That gives those HIPAA-covered entities some assurances that their business associates, who they rely on for being in compliance with the operating rules and the standards, gives them some assurance that they are in conformance with those requirements. The next slide just highlights the organizations that have achieved core certifications. Many of these organizations have more than one core certification. And on the next slide, I just want to highlight our latest, newest core participating organizations since our last town hall call, which was in September of last year. We want to welcome Aspen Dental Management, the Healthcare Business Association of New York, South Dakota Medicaid, and SureScripts, all as new core participating organizations. So that means that they will be joining us as we develop operating rules over the course of the next year. We also have about 10 organizations that have earned at least one new certification or one recertification over the past few months. So congratulations to all of those organizations. So I'm now going to move on. I hope that overview was helpful. I know it's probably repetitive for some of you, so but a good refresher. But I want to move on to the status of some operating rules that the core board, and there was a slide previously that mentioned our board, which is made up of equal parts providers and health plans as well as vendors. And one of the responsibilities of our board is to identify when an operating rule set is ready to move forward into the federal mandate process. And I'll walk through that process in a minute. But once an operating rule has kind of been approved by the core participants, it's available for voluntary implementation, certification becomes available. But in our role as a designated operating rule authoring entity, the board has a responsibility to review and consider whether or not operating rules should be mandated under HIPAA. And so on the next slide, in May of 2022, the board sent a letter to NCVHS, which is the National Committee on Vital and Health Statistics. That is a federal advisory committee to HHS on topics related to administrative simplification, but also privacy and security, population health. That committee advises the Secretary of HHS in these areas. And they also make recommendations on whether or not operating rules or standards should be adopted. The board recommended a set of updated operating rules. So for those of you who are engaged with us over the past couple years, you know that we made some pretty significant updates to the eligibility operating rules to help align them with emerging business needs like tiered benefits, telehealth, including whether or not a prior authorization is required, getting down to the procedure code level, as well as some updates to our infrastructure requirements around system availability and connectivity. Those updated rules were included in the package sent from the board to NCVHS, as well as the new core claim attachments and prior authorization attachment operating rules that were also developed in the 2021 to 2022 timeframe. On January 19th of this year, NCVHS, and we can move to the next slide, NCVHS held a hearing, and that, you know, the letter from the board prompts NCVHS to hold an industry hearing where they hear from stakeholders. Both during the hearing, stakeholders will present on the value of the operating rules, as well as invite industry to submit comment letters on the value of the proposed operating rules. So that hearing took place in January. We had several organizations from our board presented, as well as other standards development organizations, providers, vendors, and plans, many of whom, almost all of whom, were from core participating organizations. And they all, majority affirmed strong support for the proposed operating rules, as did many of the comment letters submitted as well. If we go to the next slide, and that presentation is posted on the NCVHS website if you're interested in going, or actually every organization's presentation is there, as well as a recording of the hearing if you're interested in hearing the details of the presentations and the comment letters that were submitted. So I talked about kind of the process here. So we have sent the letter, we have, NCVHS has collected the industry feedback. They are now working internally to consider what recommendation they want to make to HHS on whether or not the proposed operating rules should be adopted under HIPAA. We have generally heard that NCVHS should be scheduling a meeting to finalize their recommendations within the next couple of months. Depending on their recommendation, that would then trigger rulemaking from CMS on to mandate the proposed operating rules. So a few more steps in the process. It is not a short process, and that's one of the things that I think industry has been having a lot of discussions around lately is, you know, with the pace of standards development and technology, how can we as standards organizations and operating rule organizations and work with the regulatory process to help align with where the industry is today. So that's the status of the proposed rules with NCVHS, and as soon as we hear more from NCVHS, we will let you know where they're headed. There has been also on this similar timeline to the submitted operating rules, a lot of regulatory activity related to both prior authorization and healthcare attachments. And if we want to move 2 slides ahead, I guess, I'm going to quickly share an update here, although I'm guessing with this audience, I don't need to go into a lot of detail on what is included in these 2 new proposed rules coming out of CMS. Both rules came out in December of last year and impact the space in which we are all working. The first is a proposed rule on interoperability and electronic prior authorization from CMS. And this rule really built on a rule that was pulled back from the 2020-2021 timeframe and addressed key provisions related to APIs, including a patient access API, a provider access API, and payer-to-payer data exchange, and recommends specific implementation guides for the APIs to be used. There are a number of proposals related to prior authorization included in the rule, including a requirement for impacted payers. And I guess I should take a step back here and point out that this rule applies to public programs under public programs. So, you know, Medicare Advantage, Medicaid, Medicare, and other qualified health plans, but not to commercial health plans. And that was similar to the prior rule that came out, although that rule only applied to Medicaid programs. So CMS is using its authority over public programs to apply these requirements. The proposal includes a requirement for these payers to implement and maintain a prior authorization requirements, documentation, and decision API. That is so that they can exchange understand whether a prior authorization is needed, what documentation is required, and conduct that prior authorization using a FHIR API. There are recommended implementation guides to go with that as well. The proposal also includes payers to include a denial reason if they deny a prior authorization. It includes timeframes by which the payer must send the prior auth decision, and that decision can be approved, denied, or additional documentation needed within 72 hours for expedited requests and 7 calendar days for standard requests. And then there's some reporting requirements for providers as well. There are also 5 requests for information on other related topics included in the proposed rule as well. Comments were due on this rule 2 days ago, and so I can highlight on the next slide some of the key points in the comment letter that was submitted by CAQH. The comments related to prior authorization were really built off of the work that CORE has done over the past probably 6 to 8 years in the prior authorization space, developing prior authorization operating rules, as well as our work with the prior authorization attachments. I think an overarching comment here is concern around requiring standards for a segment of the industry rather than the entire industry. So only certain payer types are included in this proposed rule, as I mentioned, to implement that API for prior authorization. And CMS strongly encourages the commercial industry to follow suit. And the question is, will that happen? And we don't want to set up a system in which we have a bifurcated approach for prior authorization, because that makes it very difficult for providers to manage on the back end. So brought up concerns around that and the importance of adopting standards in a consistent way rather than doing some through CMS authority over public programs and some through HIPAA. We really think it should be through the same approach, and ideally HIPAA, because that applies to the entire industry. We looked at some of the potential impacts of required versus supported functionality and data content in that PAR D API and the value that is needed to drive uniformity and implementations. And we talked a little bit about some of the lessons we learned developing timeframe requirements for prior authorization in the operating rules and kind of the conversational nature of that transaction. For the API proposals, we were really supportive of the exchange of health information and APIs being a promising way to exchange all of this data. One of the concerns we've heard from the plans that we interact with is that we want to make sure that the use cases and the ROIs aligned with the infrastructure investment to develop the APIs. And finally, we commented on the SDOH data collection RFI as well, based on some of the work that CORE has done in the value-based payment space, highlighting the importance of standards, particularly around SDOH data and the need to move forward from that perspective. So that was the interoperability and electronic prior authorization proposed rule. I'm sure many of you on this call were working hard up till the last minute this week on your letter related to that. On the next slide, the second proposed rule that came out from CMS from the National Standards Group is a proposal for a healthcare attachment standard, and comments are due on that on March 21st, on Tuesday. So I know all of you policy folks have been very busy as of late. The healthcare attachment proposed rule proposes a new HIPAA standard for attachments for claims and prior authorization. And if you have been in this space for a long time, you have probably heard many in this industry complain about the lack of a standard for attachments, and that really driving some of the manual efforts around prior authorization and attachments data exchange in general. Because we haven't had a standard, there has been a bit of a lack of investment in this space. So this rule proposes both X12 and HL7 CCDA standards for attachments, as well as standards for electronic signatures, and modifies the currently HIPAA mandated standard for prior authorization and referrals from the 5010 version of the 278 to the 6020 version of the 278. I do want to bring to everyone's attention that I think just earlier today or yesterday, CMS did put out publish some updates to this proposed rule, addressing some oversights that were included in the initial version. So I encourage you guys to go out to the Federal Register to check that out, where they, I think, didn't explicitly adopt some of the things that they had mentioned in the rule. I mentioned that every HIPAA transaction is required to have operating rules earlier in my presentation. And as we move to the next slide, I want to highlight that that is the same for attachments. CORE was named the operating rule author for attachment operating rules almost 10 years ago now. So it's been a while, but we haven't had a standard. Even though we didn't have a standard, our participants felt like it was really important to build some uniformity around the exchange of attachments. So CORE went ahead and developed operating rules for attachments a couple years ago, as I mentioned. Those rules are standard agnostic, meaning they can work with multiple standards, as we had anticipated based on NCVHS recommendations, that standards for attachments may include both the X12 275, the HL7 CCDA, and even potentially FHIR. So the operating rules work and create uniformity across all of those standards. There is an opportunity here because the operating rules are currently with NCVHS for review. If NCVHS were to recommend those attachment operating rules for federal mandate, CMS could include them in the final rule for attachments. There's a lot of value to doing that. I think all of us know that implementation of new standards and operating rules is a significant lift, and we shared some of the data and the ROI anticipated from that in our presentation at NCVHS. But aligning standard and operating rule implementation for the industry will allow greater uniformity from the start and really drive progress in terms of automation. So if that's something your organization is interested in, on the next slide, we have created some resources on our website to help support your comment development. I know we're 6 days from the due date to comments here, but if you're interested, there are some links here to understand better the benefits of concurrent adoption of operating rules and attachment standards at the same time. So please take a look and reach out to us if you have any questions. So it is 2:30, we're halfway through this presentation, and I am really excited now to talk about some of our upcoming work for 2023. 2022, for those who have been working with us closely, the beginning of the year, we started off approving a whole slew of operating rule updates and new rules, including the attachments, the eligibility updates, and that kept everyone really busy for the first couple months of 2022. And then we really turned our attention to identifying the next operating rule opportunities. Where could operating rules have the biggest impact moving forward? And our team at CORE spent a lot of time working with our participating organizations and other industry stakeholders, doing environmental scans and surveys and running a few focus groups to really identify and make sure we fully understood the best opportunities. So we call 2022 kind of a research year for our team. And some of you might have been wondering, where are all the core work groups? And if you weren't necessarily involved in one of those focus groups. Well, let me tell you, 2023, this is a rule development year for CAQH Core. And we kind of go between rule development and research year to year, but this is going to be a big year for Core. And I'm excited to share some of the opportunities that we are looking at. We have gone through the research phase. We kind of have 3 steps to our rule development process. The first is identifying opportunities through our research. The next is developing the operating rule requirements through our subgroups and work groups. And then we have a formal balloting process where we have to meet quorum and approval levels with our participating organizations and the board before an operating rule can be published for implementation. Our rule development effort is going to focus on 4 main areas in 2023, although don't hold me to that. It always seems like something new comes up maybe a third of the way through the year. So this is where we are now, but you know, it's possible something else could be thrown into the mix at any minute based on industry needs and what we're hearing from our stakeholders. The first area that we are looking to develop operating rules is for healthcare claims. You may recall that we have operating rules, we have infrastructure rules for the healthcare claim, that 837 transaction for connectivity, response time, and all of those kind of traditional infrastructure operating rule requirements. But we don't have a data content rule for healthcare claims. And while there is a fair amount of adoption of electronic claims in the industry, we're still hearing challenges from providers around you know, denials and first pass rates. So I'm going to let my team talk about that more in a minute. The second is around value-based payments. We've done a lot of work to update our research from 2018. You may remember we put out a big report about 5 years ago outlining key areas for really driving administrative efficiencies and data exchange to support value-based payments. Third, we're going to update some of our payment and remittance advice operating rules. And fourth, and I'll get into this in a minute, is some collaboration with NCPDP related to the development of operating rules for including medication coverage under the medical benefit in the eligibility transaction. So with that, I'm going to turn it over to my colleague, Pete Benziger, who is leading our claim operating rule development this year. Pete, do you want to talk a little bit about the process on the next slide?
I would love to talk about the process here on this slide. Thank you, Erin, and thanks for turning the page. Hello, everybody. It's nice to see some familiar names on the line. My name is Pete Benziger, as Erin suggested, and I am the core manager leading this operating rule development. So we really look forward to the healthcare claims subgroup. It is scheduled to launch on April 13th, less than a month away, if you can believe that. I will go over here where we are in preparing for the subgroup launch, what our focus areas are going to be, expanding upon what Erin said there, and then some miscellaneous takeaways, if you will, before handing off the microphone to our next guest. So a bit of a background. Across February, just a couple weeks ago, we shared a call for participants just so everyone could register to participate for the upcoming operating rule development. To date, over 90 folks across the industry. We have payers, providers, vendors, associations, all signed up to help with our data content operating rule build. It's just the kind of representation that creates a strong operating rule making group. The goal here, again, is to develop that data content operating rule that complements our already existing infrastructure for healthcare claims. We're going to be led by 4 co-chairs. Happy to share who they are with you. We have Megan Sicorso from Gainwell Technologies, Randy Gable from Ohio Health, Olga Kabinski from HBMA, that's the Healthcare Business Management Association, and Mahesh Siddhanti from Centene. So really excited to have those co-chairs. They're enthusiastic, engaging, and will manage the group effectively, especially as some of them have experience in similar roles in the past. Focus areas for the subgroup, if you are reading through the slide here, have been guided by, I'll call it a robust environmental scan that several folks, both on the core team and I imagine some folks on the line participated in across last summer. The environmental scan was then followed by focus groups, and then the focus groups were also complemented by polling. We were sure to really dig in to understand the pain points the industry has related to healthcare claims and opportunities to standardize information that could promote or support innovation across our industry, one of our essential transaction sets. Across those interactions, conversations with industry, it became apparent to us that 3 areas were definitely in need of attention and standardization, namely, and in the middle of the page there under focus, number 1, claim status and error reporting. More specifically, that is claim status codes and claim status category codes. Many organizations, for example, use the 277 CA for claim status. However, code usage, we hear and understand, is inconsistent. Perhaps our providers on the line can empathize. Aligning on code usage for claim status has a number of positive impacts, not just for providers, but also payers and vendors alike. Number 2 focus area, as we know, the 837 has a bounty of information on it, and a question came up, what of this information can be utilized or standardized for the purposes of supporting value-based payment methodologies? Our colleague Mike will talk a little bit more about this tangentially when we turn the page here. Not yet though, so plenty to look forward to in a second. A third opportunity item, one that became immediately apparent, was telehealth claims submission. An example here, one that I know I personally have spent time trying to coordinate. What should the place of service indicator be for telehealth services? A number of POS codes are used today. I know I, in the past, have literally created a grid saying this payer likes this code, this other payer likes the other code, a cheat sheet for E&M claims, I think it was. But that was in an attempt to generate a clean claim. That's what we're going for. A clean claim is something that we know brings a smile to every healthcare professional's face when it happens. So, enough about my rambling, pulling us back to the slide here. In the bottom bullet under focus, we list a few items under consideration. Since the environmental scan that we did last summer, we've connected with folks across the industry who shared this could be an opportunity to address other claim-related issues, like, and certainly not limited to coordination of benefits, other items that might pop up as we have conversations with the group. The timeline for rulemaking, again, is we intend to launch on April 13th, meet approximately monthly thereafter. It'll probably be closer to every 3 weeks, and we anticipate 4 to 5 total meetings, depending on conversations, how conversations go, what additional opportunities come up, things like that. So, as usual, we'll solicit feedback outside of the meetings through straw polls and the like follow-up surveys. For those who are not familiar with the straw poll methodology, those inform both rulemaking and subsequent discussions that we have with our subgroup. Please do not hesitate to reach out with any questions. As you could tell, I too am enthusiastic about healthcare claims. You got our email there in the bottom left corner, and we're happy to touch base. Again, my name is Pete Benziger. And Aaron, unless you have any more to add, I believe it is Mike's turn to talk about VBP.
Yeah, great. I'd love to introduce Mike Phillips, another senior manager at CORE, who's going to be leading our value-based payment work this year.
Thanks, Pete. Thanks, Aaron. Thanks, Pete, especially for that great overview of the healthcare claims work. I'm really excited about that as well. So I'm going to talk to you about the initiative that CORE is launching this spring and setting up a value-based payment subgroup with the goal of developing and publishing operating rules that advance the goals and adoption of value-based payments. Extensive details are included on the slide, but I'm going to spare you some of the monotony of reading it word for word. Instead, I want to walk through some highlights and some key points and directions that are really going to dictate the subgroup's conversations. So beginning first with a little history of why we are pursuing rule development efforts in the VBP space. So CORE completed foundational work in 2018 to understand the barriers to adoption and implementation of value-based payment models. Through these efforts, our team identified 5 key operational areas that were really derived from a fee-for-service environment, but were applicable to value-based care. And if they are addressed through the value-based care lens, could really help automate the administrative functions of alternative payment models. The areas range from the familiar, we're all familiar with data uniformity and technical interoperability as really key themes and issues from across our industry, but considerations expanded into more, those that were more specific to VBP, such as quality measurement, risk adjustment, and patient attribution. So fast forward to 2022 and early 2023, understanding that contexts have changed since 2018, our team set out to investigate how the 5 operational areas have persisted and evolved over the last several years, and what new obstacles and opportunities have emerged during that time. To do this, our team engaged in industry research, in-depth stakeholder interviews, and formed a value-based payment focus group that helped us confirm assumptions and potential directions to take with a subgroup. Just want to pause and say thank you for all of you who participate in those efforts. I know several of you are on the line today, and just state that your input was truly invaluable. In short, our findings from those initiatives show that the relevance of the 5 operating areas is high in 2022, 2023, but still leave ample room to be addressed. What changed was the influence of health inequity in VBP, as well as the attendant need to collect and analyze social determinant of health data in VBP models. Another theme that arose was the general impact of program complexity of VBP models, which over time has steadily grown as the priorities of VBP have changed to meet existing and emerging considerations, not the least of which is the aforementioned collection and analysis of SDOH data. These areas raised new insights surrounding interoperability and data exchange and augmented, or in some cases exacerbated, existing challenges depending on your point of view. They also raised important methodological considerations as participants wrangle with complex data models used for risk adjustment and quality measurement. To address these areas, several targets were identified that inform operating rule development and industry guidance. First, I should pause and I should note that any new or updated operating rules that come out of this initiative will join a set of operating rules that were produced by CORE for the VBP space. These directly address patient attribution through a single patient attribution rule, as well as infrastructure and data content rules for roster attribution. Also note that the single patient attribution rule, which allows participants in VBP models to identify attributed patients at the point of care, is currently under consideration by NCDHS for recommendation of federal mandate. But back to the current initiative, I'm going to list in detail 4 provisional targets for operating rule development that are going to drive our conversation during the subgroup. The first, as Pete introduced previously, in collaboration with the healthcare claims effort, the group will work to identify a pathway for the submission of supplementary diagnostic information using the X12-837, the claim submission transaction. Documenting and disseminating best practices that we know exist across the industry but might be used variably. We anticipate from a VBP perspective that this can be applied to social determinants of health, but also risk adjustment and quality measurement methodologies, as well as others that are sure to be elucidated by the subgroup. The second is focused on the X12-834 transaction or other such methods that's used to carry out benefit enrollment and data collection during benefit enrollment. Right now, there's a proliferation of data sets used for the collection of sociodemographic information at benefit enrollment. This leads to downstream data integrity and quality issues, which in turn can harm the utility of the data in helping health equity efforts and the like. So we would seek through a data content operating rule to align the industry around the use of a single or agreeable sociodemographic data sets that could be used to align health plan data collection at the point of enrollment, really taking a lot of variability that's present in the market right now and wrangling it in a bit to help promote some uniformity. Excuse me. The group will also investigate the application of existing CAQH core infrastructure and connectivity rules to the administration of value-based payments, and will make recommendations for updates when operational gaps are identified. A big theme that arose during all of our conversations was the need for a consistent infrastructure for value-based payments. So we have the tools to approach that and really identify where operational gaps may exist. And finally, underpinning the holistic work, the group is going to be tasked with establishing consistent definitions of contractual and methodological components that will be used throughout current and future VPP operating rule development. I'll note that this work will not seek to align disparate or proprietary methodologies at this time, but we hope through the creation of single definitions that we can minimize confusion and implementation variability across complex contracting and VBP implementation workflows. As Erin introduced before, any of these priority areas is subject to change based on subgroup discourse or the emergence of other key information. It's a very complex field. We're hoping by starting with smaller, actionable target areas that we can make an outsized impact on the industry, but we'll really be relying on the expertise of our industry partners. We are excited to kick off this effort. We similarly expect the frequency to be about monthly or every 3 weeks across 4 or 5 meetings, supplemented with straw polls to confirm the discussions that we're having during the subgroup calls. We're anticipating a launch in late April. We're still hammering out the dates as we finalize agendas as well as our co-chairs. And alongside a call for participation, which should be released shortly and in advance of the subgroup formation, we're going to be releasing a detailed white paper of our research findings and the justifications for the listed priorities, so that you can use to disseminate around your organization and learn more about this initiative as you consider joining. So that's a very broad overview, crammed a lot into, I think, 7 minutes there. But right now, I'm going to pass it back to Erin to conclude our town hall, our talking points around rule development and other high priority areas.
Thanks, Mike. I'm almost ready to conclude the town hall too, so you were not far off there. There are 2 more opportunity areas that I want to highlight quickly that are a little less baked at this point, I would say, than the claims and value-based payments areas, which are really launching in the next 6 weeks or so. The first is the board approved at the end of last year updating our EFT and ERA enrollment data operating rules. So for those of you who have been with us a while, you might remember that there are operating rules that define the data elements to be collected when a provider enrolls with a health plan to be paid via EFT or to receive an electronic remittance advice. And the purpose of these rules is to really create a more standardized experience for providers, because that was determined to be a barrier to using EFT and ERA. Those rules were developed over 10 years ago now, and lots of things have changed in our industry, including the need for higher levels of security to prevent breaches, as well as just more electronic group enrollment efforts. So later this year, we will be launching an effort to update those operating rules. Now, those of you who are particularly savvy would say, if we update those operating rules, they won't align with the rules that are currently federally mandated. You're right. So we're also thinking through, is there a way to pilot those rules before we bring them to NCVHS, and what's the process for doing that? So we welcome any of you who are particularly interested in this topic to reach out and get engaged as we're going through the planning process here. We will be working with NACHA, the operating rule author for the financial services industry, who we initially developed these rules with as well. Additionally, we have agreed to do some joint operating rule development work with NCPDP around the eligibility transaction, particularly related to the development of a eligibility data content rule that addresses the exchange of medical or medications covered under the medical benefit. This information is often not returned currently with eligibility transactions and could be extremely helpful for our providers. So that's another effort that we'll be launching later this year, and we're in the process of planning for with NCPDP now. With that, I just want to highlight some of our upcoming events. On slide 28, we are really hitting the road this spring. It seems like the in-person conference world is almost completely back. So I will be speaking at HIMSS with Marilyn Henne, who is one of our core board members representing the American Medical Association. And if any of you are planning to attend HIMSS, please join us at this session. We would love to see you and meet you and talk about how we can drive adoption of operating rules. Additionally, our team is speaking with the dental community around the value of operating rules in the CAQH index findings, which have some specific data related to the dental industry and their adoption of electronic transactions. We'll be at the Revenue Cycle Leaders Forum in Nashville in May, as well as presenting with leadership from the standards development organizations at the WEDI Spring Conference at the end of May, which is virtual this year. So we hope to see you all out on the road. Additionally, we are continuing to develop our webinar and education content for 2023. So be on the lookout for upcoming webinar programming as well. And I just want to end today's session before we open it up for questions, and please do submit questions if you have any. On the last slide, you heard a lot today about kind of the historical impact of operating rules and what's coming up in the future. We are looking at claims, at value-based payments, at pharmacy benefit coverage, and security issues around EFT and ERA enrollment, as well as continuing to have that conversation around the importance of operating rules being standard agnostic and what does that mean moving forward as the industry is at this crossroads between sort of existing legacy transactions and looking forward to the value that APIs can bring, as we're seeing in some of these proposed rules. We need organizations like yourselves to be at the table, to participate in these conversations, to develop the operating rules, to make sure they are as impactful as they can be across the industry. So I really encourage you, if your organization is not already a core participant, to consider joining us as we develop these rules this year. I also want to emphasize the importance of becoming core certified and demonstrating your conformance with the operating rules. CMS does conduct audits on the federally mandated operating rules, and this is a great way to ensure your systems are in conformance with those operating rules. We also are continuing with our pilot and ROI measurement efforts. We have a couple different pilots underway right now related to the attachment operating rules, and we are always welcoming organizations that are either already in the midst of an implementation or planning to implement operating rules or new standards. We use our skills both from the CAQH index team and our research and measurement team to support your work and think through ROI metrics to be able to report out more broadly what this type of implementation of standards or operating rules would have on the broader industry. And then finally, one thing I can't emphasize enough and have heard in my conversations throughout this spring is the importance of being an advocate and being aware of the impact standards and operating rules have on your everyday operations. If you are a VP of revenue cycle at a health system, you may not be in the weeds of the loops and the segments and the X12 standards, but that detail has a huge impact on your practice management systems performance, the data you're receiving, and your ability to drive revenue within your own organization and improve customer experience. So I would encourage you, regardless of your organization type, to stay engaged, listen to what's happening at the regulatory level, listen to what's happening at the industry level, and incorporate those lessons and learnings into the decisions you're making within your organizations and how you participate and engage with the broader industry. So with that, I will turn it back over to Jackie to wrap things up.
Thanks, Erin. And Sarah, if you go to the next slide, we do have just a few minutes left. So if you have any last-minute questions you want to ask, you can go ahead and do so on the right-hand corner of your screen under that questions panel. In the meantime, Erin, you mentioned the index briefly on the last slide. Do you think you could share with anyone who might have missed our index webinar where they could find the report on our website?
Yeah, absolutely. If you go to our website and look under, I think it's actually linked straight from our homepage at caqh.org, is the full index report for this year. A lot of interesting data in that report. The data comes from the year 2021, so kind of the second year of COVID, where we're seeing the impacts of increasing utilization again, but also the costs of staff shortages, staff that may be less trained and taking more time to conduct transactions, and the higher salaries that you know, the staff are commanding given the staff shortages. So it's leading to costlier transactions and actually greater savings opportunity. So it's a really interesting report this year, and it'll be interesting to see kind of where the industry ends up next year based on some of the findings from this year. So would definitely encourage folks to look into that.
Great, thanks, Erin. I'm not seeing any more questions come in, but I would just like to remind anyone who would like to get involved with our rule development initiatives this year to please go ahead and shoot us an email at core@caqh.org, and we can go ahead and help you with next steps in that process. And same goes for if you have any questions after the presentation today. And with that, I just want to thank everyone for joining us during our first town hall this year. And I hope you all have a great rest of your afternoon.